Ischemia, most easy thing to be seen on ECG. And the key is J point. Now what is J point? These are the changes you can get in ischemia. I'm not going into the details. You all know, you see them daily. This is the J point, where QRS ends and ST starts. That's the J point. Whenever you're seeing your ECG, try to stick, where's the J? Oh, is it J is at level, it's elevated और सबसे मुश्किल काम ये होता है कि ये फैसला करना QRS एंड कहाँ हो रहा है और ST, वो जब आप मुस्तकिल देखते रहेंगे तो आपको आइडिया होना शुरू हो जाएगा कि ये वो एक्यूट एंगुलेशन पार्ट था, ये खत्म हुआ और यहां से ST शुरू हो रही है. And how to judge then after assessing this J point? You have to compare it with TP segment. The preceding TP segment से उसको compare करें, J up है या down है. और इसके लिए मैं बार बार कहता हूं, you need a ECG recording in straight line. कॉम्प्लेक्सेस यूं या यूं है तो ये असेसमेंट नहीं हो पाएगी. और इसको बस सिर्फ ये देखना है कि वो J पॉइंट. अब टू डायग्नोज MIs you need to know different leads, territories, at least 2 leads along with symptom. Remember, along with, not without symptom. SK लगा देते हैं. यंग आदमी atypical pain, ST elevation, SK. बाद में ट्रॉप भी नेगेटिव, ECG भी नॉर्मल, सब कुछ ठीक, क्योंकि पहले ECG बाद में मरीज. This is the evolution. If you have doubts about ST elevation, try to see the preceding ECG and follow the ECGs. In acute MI, you should have this kind of evolution. Initial A, then slightly ST elevation and T increasing. If right from the beginning your ECG is like this and subsequent ECGs are also like this, then it can be normal variable, which happens in young age people. Your anterior leads can have ST elevation, concave, a bit concave type. So always judge when your symptoms are plus minus preceding and subsequent ECGs, because this is stage C. Then after that you will found this, and then this T start coming down, and then Q. So even on next day someone has diagnosed someone MI and you found same this ECG, then question the diagnosis. Got cardiac markers. There may be something wrong with the diagnosis. So it's important to know this acute evolution of transmural infarction and changes which you can got in this. That can help you in at least diagnosing. Yeah, there is something wrong with. Oh, its battery is getting low. So can someone help me to put the cord? I have cord in my bag. Just attach the cord to this laptop and. Now apparently it looks MI, but never see it like that. कि बस ये MI का patient है. Go and see every lead, look at the J point and assess the amount of elevation or depression. I am giving you 15 seconds. Just give me the answer. Oh, we have lost. जल्दी लगा दें कहीं पे भी. हाँ, इसको अपने अच्छा उस पे लगा दिया आपने. एक्सटेंसिव इंटीरियर नहीं चाहिए. यही तो प्रॉब्लम है आप लोगों का. नेवर डायग्नोज ECG when you are reading. When you are reading ECG, just read the things what are there. So tell me what's there in terms of ST elevation and depression. ST elevation of at least 5 to 6 millimeter in chest leads and 1 to 2 millimeter in VV1, AVL, even 3 millimeter. And ST depressions in lead 3, AVF around 2 to 3 millimeter. That's the way to narrate this ECG finding. And then conclusion, you can say that this is extensive anterior wall MI because he's having that much ST elevation and depression in those leads. Territories you need to know to diagnose MI. ST depression, again the same principle, J point और फिर इन चीजों को देखना है. इसमें हम ज़्यादा वक्त नहीं लगाते. Similarly, just go through this ECG and give me the answer regarding ST depression. How much ST depression in which leads? 2 to 3 millimeter ST depressions. Here an elevation. Just look at the J point. Hyperacute T wave, this I already have showed what it means. It may be hyperkalemia, it may be initial evolution of acute transmural infarct. So what we are going to decide? Symptoms, background, whatever. Q waves, first downward deflection, at least 2 millimeter on 1 millimeter, 1 small square wide. इसमें मैं टाइम अपने ये सारी वो चीजें हैं जो रिकॉल हैं आपको पता होनी चाहिए और आपको देखनी चाहिए ईसीजी में. तो इसकी बस चैम्बर एनलार्जमेंट, लास्ट पार्ट ऑफ ईसीजी रीडिंग. वी हैव कवर्ड बेसिक्स, we have covered access, we have covered rhythm, we have covered ischemia,